Welcome back to the CTO Demon channel, my CTO Demon friends. Today we have another core curriculum talk, and it's the penultimate talk on the global consensus recommendations for safety of CTO PCI. This talk is going to include several things: the vascular access issues, the contrast issues, the radiation injury issues, and those issues in three sort of sets are presented together here. So first, for vascular access. Now, a lot of this is relevant for both regular PCI as well as CTO PCI. For vascular access, radial access has been demonstrated to have a lower bleeding complication rate than femoral access. So its best choice really is bilateral radial, whether it's proximal or distal radial and left and right radial doing it together. It has the same success rate as femoral, at least in the studies that's been done. For me, however, in my practice, I'm still a one radial, one femoral guy. The reason is really the other radial I still have to bend over quite a bit. And if it's a long procedure, unless you do a distal left radial, the patient's arm is quite uncomfortable for them too. So I'm still a radial femoral guy. But leave a comment below if you feel differently. And I know there are some staunch biradial operators out there. And certainly I've done a few dramatic live cases through biradial approach, and they've been successful too. So secondly, if we do femoral puncture, of course, fluoroscopy and ultrasound guidance for femoral artery puncture and the puncture with micropuncture needle, this kind of clean technique is useful. It reduces the bleeding complications. The use of long sheaths in the femoral artery can stop the guiding and the sheath moving back and forth. And if it moves back and forth, especially if you use the femoral for the retrograde side, I find, is that it's got this cutting effect. And sooner or later, if you're struggling with retrograde and pushing things in and out, you start getting a hematoma, and then the blood pressure starts dropping. And that's very frustrating. So it's best to use a long sheath that doesn't move in and out so much. Most cases, if you do CTO, you're going to have two access. So one very useful tip is that if you close the femoral, use the other access, use a radial and a long MP catheter, take an injection just to check things are fine. And if you need to stop bleeding, of course, you can use the other side to use a balloon to tamponade the bleeding. Okay, that's all we have in the paper for the vascular access. For contrast-induced acute kidney injury, you can reduce this effect by reducing the contrast toxicity. This, is to reduce the toxicity of contrast by hydrating the patients, by administering statin and discontinuing nephrotoxic drugs, and not starting a procedure if you see the creatinine is climbing up. So setting the patient so that he can tolerate the contrast. The second, of course, is to reduce the contrast dose. The recommendation in the global CTO algorithm paper is to have a contrast dose less than 3 times the estimated glomerular filtration rate. And of course, this has to be even less in patients with significant comorbidities that increase the risk of acute renal injury. Contrast volume can be reduced, and the recommendations we give in the safety consensus paper is to analyze previous angiograms very carefully, optimize the timing in retrograde and antegrade injections, use mitral catheter tip injections both for proximal cap and for retrograde filling. And the use of retrograde approach is very useful. So in patients sometimes with borderline renal function, I would opt for choosing retrograde rather than continue on antegrade, especially if the lesion is already calling out for a retrograde approach. Use of biplane, use of IVUS, these can all reduce contrast dose. Finally, radiation injury. Radiation in CTO PCI, again, the global algorithm recommends that if the air current dose is greater than 5 grays, we should stop the procedure unless it's already well advanced and we're already waiting to stent. The reduction of total radiation dose can be done with well-known, well-described techniques like reducing the frame of fluoroscopy down to 7.5 or less frames, avoiding the steep angles, using fluoroscopic store rather than cine whenever possible. Further reduction of the radiation dose can be done by using trapping techniques, like a trapping balloon when you exchange, so you don't have to watch the microcatheter go in and out very far. Using a marker talker on your wire so that when you change wires, you don't have to keep watching it. Keeping it so that it goes just to the microcatheter tip. And also you can use detailed pre-procedural angiograms to plan your system. Some X-ray systems also have a way of detecting the operator's eye so that when you're looking away, the X-ray stops. And of course, you can do that by reminding yourself to take your feet off the paddle when you're not looking at the X-ray screen. So those are all methods that can reduce the radiation dose. But apart from reducing the dose, you can reduce the concentration, because the problem is not the radiation dose. The problem is the radiation dose all in one spot of the skin that causes the skin to then have radiation injury. So some machines, like the Toshiba machines, have this built in, and it will detect those of concentration, and you can plot out the site and where the problem is, and it can recommend changing angles, angles it can recommend, and you can change the angle to reduce the injury to skin. Of course, things like radi pads for patients and a bit of lead put over the particular area that's already been damaged from previous procedures, that's very helpful to reduce the concentration of radiation to the patient. Patients who have more than 5 grays should have follow-up, and we recommend a follow-up at 30 days, a clinical inspection, preferably with a photo, so that we can document the damage to the skin, and we have a reference to compare it with. So those are the recommendations in the global consensus recommendations for safety of CTO PCI. And I know this is a little bit boring because these are things that are common and everybody's been published, but I think for completeness sake, we should include this in our video. And these things are important for the patient, because a successful procedure is not as good as a successful procedure when a patient doesn't have any complications afterwards. So I hope you have patients that remain free of renal injury, free of bleeding injury, and free of radiation injury. And please refer to the paper that's now finally been accepted and will be published in Heart Lung Circulation before the end year. I'll try to put the link of the paper in the description below. Again, if you like, please press the like button and do subscribe for the final talk on the safety recommendations from the Global Consensus Group. See you next time. Bye-bye.